You know that feeling? Just drowning in information, stacks of papers, research, and you're just trying to figure out, okay, what really matters
Yeah,
here?
what's the key takeaway? That's what we try to do.
Exactly. And that's what this deep dive is all about. Today, we're tackling something really fundamental in healthcare, evidence-based medicine, EBM.
We're going to look at where it came from, some of the, let's say, challenges it's faced, and how things like tech and data might be, changing the game.
Right. And we've pulled together quite a bit for this history, critiques, a paper that kind of pushes back on the traditional view of evidence.
Plus a classic text on just, well, being a good clinician, and some newer thinking on precision education in medicine.
So our goal, our mission today, is really to unpack this tension. You've got the push for standardized protocol-driven medicine
Based on big population studies?
versus the absolute need for care that's tailored to you, guided by a doctor's experience and judgment. What do our sources suggest is the way forward?
Okay, so let's start with the basics. What is evidence-based medicine? Our sources trace it back, but the modern idea really got cemented around 1996 by Dr. David Sackett and his team.
They gave it that definition, right? Something about being conscientious.
Yeah, the conscientious, explicit, and judicious use of current best evidence in making decisions about individual patient care. That was the line.
Explicit and judicious. Okay.
Yes.
And they talked about a triad, these three core parts.
That's right. The idea was you need to balance three things. First, the best external evidence, research findings, usually from studies.
Okay.
Second, the clinician's own expertise, their skills, their judgment, their experience.
Makes sense.
And third, crucially, the patient's values and preferences. What matters to you?
So it's not just about the studies.
Ideally, no. And this framework, well, it really took off. Our sources show it got built into medical training, residency programs, hospital policies, clinical guidelines. Everywhere, really.
So if the goal is using the best evidence, it seems like a natural step to creating all these guidelines and protocols we hear about.
It absolutely did. But almost right away, people started raising concerns. One big one that pops up in the sources is this worry that focusing too much on protocols could actually, well, limit a doctor's freedom to make the best call for an individual patient.
Yeah, I remember seeing a critique from '97. Feinstein and Horowitz, they were pretty respected figures.
Very respected. Pioneers in clinical research methods, actually. And they basically warned, look, the goal of using evidence is great, obviously, but it can get undermined if the best available evidence you're relying on is too narrow or maybe not even that high quality for the specific question you're asking. Their big worry was relying too heavily on statistical averages from big groups. They felt it could make us overlook how different individual patients really are, that, heterogeneity.
So the average might not apply to you specifically.
Precisely. And the sources touch on related statistical issues, too, like over-reliance on p-values.
Ah, yeah, the magic number.
Right. And the potential for panking, maybe unintentionally, maybe not fiddling with data until you get that significant result, makes things look stronger than they are, perhaps.
Okay.
They also mention how we rarely do N-of-1 trials. Those are like the ultimate personalized trial, just for one patient. Super strong evidence for that person, but, well, really hard to do in practice.
So this leads right into that core tension, doesn't it? The institutions wanting strict protocols
Often tied to quality measures or even payments.
versus the need for that personalized clinical judgment call at the bedside.
This is where it gets really interesting and, frankly, a bit concerning, according to some sources. The incentives for institutions can really push towards rigid adherence to guidelines.
And that could potentially squeeze out the nuanced thinking needed for a specific patient.
That's the fear. There's an example in the sources about sepsis treatment, giving a specific amount of intravenous fluid, 30 milliliter per kilogram.
Okay, I've heard of fluid boluses.
Right. But this specific recommendation, the sources say, was based on, let's call it lower quality evidence. Yet, it got tied into hospital quality initiatives, the kind used by Medicare and Medicaid in the U.S. for payments.
Oh, so money gets involved.
Exactly. So the hospital has a strong incentive to make sure everyone gets that exact amount, even if a doctor thinks this particular patient might need more or less right at that moment.
Wow. So a rule potentially driven by payment structures could override clinical judgment for you.
That's the potential conflict the sources point out. And then there's just the sheer volume of it all.
Yeah.
Never-ending guidelines, they call it. Plus the mandatory EHRs, the electronic health records.
The charting burden.
Huge. Doctors spending, more time clicking boxes than actually talking to and examining patients. It really impacts that human connection.
Yeah, absolutely.
And another really critical point from the sources, most big trials, the RCTs and the guidelines based on them, they tend to focus on one thing. One disease, one treatment. Unimodal is the term used. But many patients, especially as we get older, have multiple health issues going on at once. Multimorbid situations. These single-focus guidelines just aren't great for that complexity.
Right, life isn't usually that neat.
Not at all. It hinders that kind of systems thinking. You need to see the whole picture. EBM, built around group averages, kind of struggles with deep individual differences and sometimes incorporating patient values effectively.
Which really brings us back to the value of, well, the traditional skills, doesn't it? The hands-on stuff.
It does. And that's why a source like the textbook clinical methods is still so relevant. Even the 1990 edition, well into the EBM era, it hammers home the importance of doctors mastering the techniques and analysis of clinical data. The stuff you get from really listening to the patient's story, a good physical exam, interpreting labs carefully.
That sounds exactly like the clinical expertise part of that EBM triad we started with.
It absolutely is. It's a reminder that figuring out what's wrong and how to treat it is, well, it's more art and science than just plugging numbers into an algorithm. It takes observation, listening, interpretation. Skills a clinician hones over time.
So, given all these, let's say, limitations, especially for complex cases or maybe situations where the standard evidence isn't clear, do we need to think differently about what counts as evidence?
Well, one of our sources argues exactly that. It's a paper called Beyond Randomized Trials, Rethinking Evidence-Based Medicine. The authors, Jacobs and Bradley, they argue that putting RCTs on this untouchable gold standard pedestal, while often dismissing other kinds of evidence, can be really problematic.
Especially for certain kinds of health problems.
Yes, particularly complex ones that are tangled up with social factors, poverty, housing, stress, nutrition, Trying to study those with a standard RCT is incredibly hard. Too many variables you can't easily control or even measure.
Makes sense. They used an example, didn't they? Ear infections.
Yeah, otitis media, ear infections in remote Aboriginal communities in Australia. It's a huge problem there, linked not just to germs, but also to housing, diet, social stress, a whole web of factors.
And the RCTs didn't give clear answers.
According to the paper, no. They ran several trials on treatments, but the results were contradictory or showed no real difference. A treatment that seemed to work in one place didn't work somewhere else using the same trial design.
So just running more and more RCTs might not be the best path forward there.
That's their argument. For these really complex, socially embedded problems, they suggest maybe we need a more individualized approach, tailoring treatments based on the specific child, the family.
And where would the evidence for that come from?
Well, they suggest maybe we need to give more weight to things like expert clinical opinion or maybe case series studies where you track outcomes in a group but without a control group. Things currently lower down the traditional EBM evidence ladder.
So questioning the hierarchy itself.
Kind of, yeah. Especially for these complex situations, they suggest maybe funders and guideline developers need to rethink how they value different types of evidence when social factors are so dominant.
Okay, so we've seen EBM's rise, the move to protocols, the critiques about individual care and judgment, and this push to maybe broaden our view of evidence. Where does all the data and technology we have now fit in?
This is where it gets really forward-looking. We looked at a source from the American Medical Association, the AMA, talking about something called precision education.
Precision education, like precision medicine.
Kind of the same idea, but for learning. It's about using data and tech to make medical education and ongoing professional development more personalized, more efficient, and, importantly, giving the learner more control, more agency.
So like how Amazon or maybe Wayfair uses your data to suggest things, but for doctors learning.
That's exactly the analogy the source uses. They argue this isn't just a future dream. It's already starting to happen because learners themselves are using tech to customize how they learn, and they see it as essential for tackling some stubborn problems in medical education.
Like what kind of problems?
Well, things like truly assessing competency, knowing what a trainee can actually do, that's been tough. But they argue if you leverage all the data in digital systems, you can get, quote, abundant, feasible assessment.
Interesting. What else?
Transitions. Moving from med school to residency or between training stages, that can be bumpy. Precision education, where data about your skills and experiences follows you with fidelity, accurately could smooth that out.
And equity. Does it help there?
The hope is yes. By creating more objective, holistic models based on data for things like recruitment or promotions, you might be able to identify and reduce biases in the current ways of doing things.
Okay, these are big ideas. Are there concrete examples of how this is playing out?
The AMA source gives a few. One is mining EHR data, the electronic health records, to automatically track what medical students have actually seen and done.
Instead of them just writing it down.
Exactly. The system sees which patients they interacted with, what procedures were logged. It identifies not just what they have seen, but crucially, what they haven't seen yet.
So you can fill the gaps in their experience.
Precisely. Then for residents, they talk about linking their actions in the EHR directly to patient outcomes, like how well are their patients with diabetes or high blood pressure doing over time.
Wow, direct feedback.
Right. They can get dashboards showing where they might need to improve, connecting their daily work to actual results for patients.
Okay. And what about for doctors who are already out practicing?
There's an idea of using EHR data to predict who you're likely to see soon. Based on the patient's record and your past patterns, the system could feed you just-in-time learning resources.
Like a quick update before the appointment?
Yeah, maybe the latest guideline summary for that patient's condition, or info on a new drug they're on, delivered right when you need it, potentially making you more prepared and efficient.
Okay, so let's try and pull these threads together. We started with EBM, its focus on population data trials,
Which led to protocols, guidelines, standardization.
but also critiques about losing the individual focus, maybe sidelining clinical judgment.
Right, that core tension.
And now it seems like data and technology, through ideas like this precision education, might offer a way to maybe bridge that gap.
That seems to be the potential. Using data to understand individual performance, tailor learning, connect actions to actual patient outcomes from EHRs. It could bring back some nuance, maybe counteracting the rigidity of just following protocols blindly.
So using data to personalize again, but in a new way.
Potentially, yes. But the sources also flag some big hurdles.
Like what?
Well, getting all these different systems, EHRs, educational platforms to actually talk to each other smoothly, that's interoperability, and it's a huge challenge.
Yeah, I bet.
And making sure these tools are available to everyone, not just doctors in big, fancy, well-funded institutions. They call it democratization. We need to avoid creating an even bigger gap between the haves and have-nots in healthcare tech.
Good point. So it's been quite a journey in this deep dive, from EBM's core ideas and reliance on trials.
Through the rise of protocols and the real challenges of applying population data to unique individuals.
To now seeing how data and these precision approaches might bring back some personalized elements informed by real-world results.
It really shows how medicine is constantly grappling with complexity, trying to find that balance.
So here's maybe a final thought to leave you with. How will all this play out for you? This constant evolution of what counts as evidence, the integration of ever more powerful technology, and let's not forget, the absolutely vital, irreplaceable role of human clinical skill and judgment. How will all that shape the future of the care you receive?
Definitely something to keep thinking about.